Great, thank you very much indeed for inviting me to speak today. I'm really honoured and it's a real privilege to be able to come and talk to you all about the work that we've been doing to understand real life care in ITP, and also to be able to thank you all for all the kind of hard work and engagement for helping us move things on. And you will see, there's some really great stuff going on at the moment, so hopefully you'll find it really interesting. So I'm Vickie McDonald. I'm a consultant haematologist at the Royal London Hospital, and I'm also the chief investigator for the UK Adult ITP Registry, which is based in London. So this is the Royal London Hospital, which is part of Barts Health, and this is our research academic unit, the Blizzard unit at Queen Mary University of London. So why is the UK Adult Primary ITP Registry important? I mean, we know it's important, you know it's important, but broadly speaking, there are some really important themes around registries and what in the medical term is called real world data. Because when companies do studies on medications in patients, often it's very, very defined entry criteria with very defined monitoring and very specific measures put in place so that things are equivalent in different treatment groups. But that doesn't always relate to how patients present in the real world, how patients' journeys are managed. And so the kind of registry element and the kind of grouped data for rare diseases is really helpful and really important. So if we look here at my kind of circle of the UK ITP Adult Registry, the areas that we're looking at in this kind of real world evidence are presenting symptoms and severity of ITP, responsive to treatments in the kind of real world info, so not very narrow specified trial data, whether we can look at associations with other conditions, and whether we can look at genetic causes for ITP. And within the primary ITP registry for adults, we also have a kind of smaller group of ladies of childbearing age who have children. And that's to help us understand how ITP can behave in pregnancy, what pregnancy may do to somebody's pre-existing ITP, and how the babies are. And because ITP is rare, and because then the ladies of childbearing age within that group are also a small number, and unless we gather lots of information from across the country, it's very difficult to have enough numbers to really understand and research properly. So who is our team? Some of these people you will know, some of these people you will know very well, some may not be such familiar faces, and not everybody unfortunately is on there, some are a little bit camera shy. So I'm now the chief investigator, and I've taken that mantle on from Dr. Proven, who I'm sure a lot of you will know. And we have Dr. Sue Robinson, who's pictured here, who's a consultant at Guy's and St Thomas's, who helps lead on the pregnancy registry, and she's an expert in pregnancy ITP in particular. We have some data managers who help with how the data fields look, and making sure that if there's little gaps in there, that we go back to the sites and say, could you please put this result in, or can you chase that? So sometimes you may find sites will also say, can you just remind me of this result and that result? So we've got as much information as we've got. So we've got Haroon, Atika, and Caitlin, although this was Caitlin. Caitlin's now moved on to exciting things as a medical student. We've had clinical trials fellows from our Barts clinical trials team. So these are doctors who are training to be haematology consultants and who come for a year to help with clinical trials at Barts, both of drug comparisons, but also helping them understand how it's important to have these registries up and running. And so Abbas was one, Sophie and Priyanka are the two that are camera shy, so we haven't got any pictures of them. And then the additional members of the study management team, and again, I mean, a lot of these people need no mention, but Dr. Proven, Professor Newland, and Louise Taylor, who I'm sure quite a few of you will know, who's our ITP nurse at the Royal London Hospital. So that's our team. And where are we based? So this is the Royal London Hospital, and then we've got the Blizzard Institute. I thought that it's quite snazzy inside, so it's a nice picture for you to see the laboratory, because we do collect DNA samples for analysis as well. And this is St Thomas's, which is where Dr. Robinson is based. So how do we recruit ITP patients? How do we get enough data? How do we encourage patients to come in? And how do we do it safely? So it's a study, it's registered with all the relevant ethics committees and regulatory authorities. And within that, we then have to have what's called a trial protocol or a study protocol, which defines what we are and aren't allowed to do. And so for the registry, we have a protocol for recruitment that talks through what has to happen with regards to patients being recruited. And for many of you who are already part of the registry, your sites will have asked you whether you're happy to be involved. If you were one of the very original recruits dating back to 2007, it may be that the registry at the time wrote to you, but there was a period of time where it felt it was more appropriate that the team spoke to you because they see you more often. Then we add you onto a participant's log, and at that point you are given a code, and from then on in you are known as your code, and that means that all the information that we hold is anonymised. There is a log kept by the sites of who's got what code so that we don't doubly enter people, but from our point of view and from the database point of view, you are a code, which means that your information is anonymised. And if you also consent to give blood, then again that's allied to that code, and we extract that for DNA. So we've got information about your ITP and how it's been managed, and also DNA. And since COVID-19 came into play, fairly quickly off the marks, we realised a lot of patients would not be coming up to hospital, and so now actually we can consent remotely, and the process is slightly different. And for those of you that may want to join via your hospital sites, then if you speak to them, what we do is we send out the consent form to you. We talked to you about it before. We send you out the consent form and the information sheet. You then phone to have a discussion, sign a copy, send it in, we countersign it, and we phone you to check that you're happy to be consented. So because we didn't want for things to be suspended. So what does the database look like? If you're trying to envisage, how do we do this? What do we collect? What does it look like? What kind of information do we want to know? And how will that help us start to understand ITP? So we use a system called REDCap, which is a secure database, and it sits within both the university and the trust firewall. And like I said, once the information is entered, it's under a code. So then you shouldn't be identifiable from the information that's in there. And we have two arms. We have the adult registry arm and we have the pregnancy arm. And depending on which one the sites collect when they're putting your information in, it will take you to lots of different questions, not you, the sites, to lots of different questions about you. And these are kind of, we have a little traffic light system for each entrant that goes in. So has the site entered your details? And if that's all filled in, it goes green. If it's not relevant, it's grey. If it's partially entered, there's some kind of blue and yellow. And if there's important bits we need to chase, there's red. And so it gives a traffic light system to the teams to help you. And if there are bits that we need to chase because something doesn't quite make sense, or sometimes the dosing doesn't quite make sense or something, then we can go back to make sure it's really good and clear. And this is what the pregnancy one looks like. So again, there's slightly different data sets for pregnancy because we want to know whether ladies have needed new treatments, what's happened at delivery, how the baby was delivered, and also a little bit of information about the baby as well with regards to platelet counts and things. And if you have more than one baby, we can go in and add subsequent pregnancies as well. And we have a lot of recruiting sites. So we recruit from about 70% of UK, 70 to 75% of acute UK trusts at the moment. Some sites with COVID and other things are only doing data entry, which is fine for a period of time, whereas most sites actually are still actively recruiting as best they can. And this is very small, but it shows you how many sites we have got recruiting into the study. And so moving on then to how many patients have we got and what information are we starting to get out. I tried to put it in as simpler terms as possible because sometimes some of these medical charts can be really confusing if you haven't got time to sit and think about them. So we're up to 4,140 patients recruited to date, which is a big number, and I would argue the biggest internationally. Some other countries do have registries, but not as cohesive as the United Kingdom one, and the other sites at the United Kingdom and our patients are great at wanting to be involved. And this chart here shows you the recruitment figures over the years as it's got bigger. So it wasn't always actually a national registry. Originally, it was a local registry that Dr. Craven set up. So the numbers were a bit lower, and then as it became national, it really moved upwards. We had a period here where we were trying to rewrite some databases and sort out some of the coding and technology things. So there was a little while where we had to suspend recruitment. So we had a bit of a dip down, but you can see that we've got a great upward trajectory, generally speaking, of recruitment, which is fantastic to see. And this really is a great number actually for what is a rare disease. 2020 is challenging with COVID, but all credit to the sites for still putting cases in. And you don't have to go in the minute your ITP is diagnosed. So patients can be recruited at any time. So just because if you wanted to join, you can't join now, doesn't mean to say you couldn't join in a year's time if logistically that is better for you. And this is a bar chart for the pregnancy. So we have to remember that ITP is rare. And within that, it's only women of childbearing age who might be eligible to have a baby. And within that, not everybody has a baby. So although these numbers don't look great, actually, as a kind of percentage of people that could go in, these are really excellent numbers. And if this continues, we're going to have some lovely, lovely data sets for being able to understand what happens in ITP in pregnancy. So this is our split, men and women. So we've got more women than men. And that we would expect, because generally speaking for autoimmune diseases, particularly in those under the age of 60, these diseases are more common in women than men. Interestingly, once we're over the age of 60, it becomes slightly more common in men than women. But that mix is roughly what we would expect. So that's good that we've got a good representation if we're trying to make conclusions. And the average age for men, as we just said, it gets a bit more common in men as they get older, 57 years, and for women 46 years. So this is all very in keeping with what we want to see, and that's very reassuring when we then try and look at analysing data. And our ethnic mix, majority Caucasian, with smaller numbers of the other ethnic groups. And broadly speaking, will generally reflect United Kingdom, although I suspect we have some underrepresentation for these groups. And that's certainly a piece of work that I think would be really helpful to look at, is how we then increase representation within our ethnic minority groups. So looking then, when was the ITP diagnosed of all those patients that have been recruited? And the vast majority, it's most recently. But what is superb about this registry, and superb about my predecessor setting it up, is we've got here actually quite a big number of patients who had ITP diagnosed a long time ago. And that's really, really helpful when we look at how treatments have changed and we look at how patients may respond differently to treatments. It's so helpful to have this data going back such a long way. So we're really lucky in that respect. And there are some treatments that we used a lot more a long time ago, arguably things like splenectomy, that we don't really use so much now because we've got more medical therapies. And it really helps us understand how these might fit into the patient pathways. So most patients diagnosed after January 2008, but a significant number of patients with ITP from a long time ago. So looking then at all the patients within the registry, what's their average red blood count, what we call the hemoglobin? What's the average hemoglobin? What's the average white cell count? And what's the average platelet count? And it should be that, generally speaking, this hemoglobin and white cell count should be, on average, if we take everybody and then even it out, should be broadly normal. There will be some who have a low blood count because they're bleeding when they are diagnosed with ITP. But you can see here, on average, it is normal. This is normal, 136. And it's a bit more in men and women, and that is completely normal as well. And then reference ranges for hemoglobin in men are higher than they are for women. And again, the white cell count is completely normal. So this is all very much in keeping with, this is primary ITP and what we want. And the average platelet count is 32 for people that are entered into the registry. And that reflects a range. So there will be some patients who have a lower platelet count, but there's quite a few patients who are diagnosed with ITP with a platelet count of 50 or 60 or 70 who don't necessarily need treatment. And so that's why the average, the middle value, isn't super low. And slightly arguably higher than men and women, but that's not different when you actually look at all the measurements properly. So what treatments are we using then in the UK for ITP? And this is the beginnings of more complicated work that we're doing, looking at how treatments are being used differently and what the response rates are when we divide them up. I'm going to talk a little bit more about some rituximabs and splenectomies in a minute. But this is a chart showing in 10-year brackets, so the most recent 10 years, 10 years before that, and 10 years before that. Each of these lines represents a treatment that you may or may not have had when you're watching this: azathioprine, rituximab, a splenectomy, mycophenolate, and the TPO-RAs. This is romiplostim and eltrombopag. And you can see that we don't do so many splenectomies now. 20, 30 years ago, up to 40% of patients might have had a splenectomy, which can carry significant side effects. Some patients do very well, some patients struggle a bit afterwards, and we do very few now, because we're using a lot more of these medical therapies that are coming through. And as these numbers come through, we can start to put all this information together and look at how people respond. Now, these are some very pretty pictures, and I wouldn't worry too much about the detail bits, but what I wanted to show you was how, as we get a bit more information about these different treatments, one of them being rituximab, which is a medicine that suppresses the immune system a little bit to help control the ITP. We can start to look at, well, within these patients that have had rituximab, these hundreds of patients that have had rituximab, we can look at different doses and say, if we give a less dose, can we find that we get fewer side effects, but the response is exactly the same? And this is what we've seen with rituximab. We've been comparing the different doses, a lower dose and the standard dose, and saying, well, actually, our complete response rate for patients, so platelets over 100 absolutely fine, is the same. And our partial response rate, platelets over 50 and absolutely fine, is also the same. So arguably, we don't need to give as much. And this is telling us the same thing with the platelet count, that these little average boxes here, there's some dot outliers, but these little average boxes are essentially the same across all of these things at different time points with the 2 doses. So by putting all this data together, we've been able to say, well, actually, it looks like those are both the same and we don't need to give way more drug. We can go with a low dose and we know that we're going to get responses. And the same that we've also been trying to look at splenectomies and understand where a splenectomy might fit, because some patients in some areas it's difficult to get some of the treatments without a splenectomy being done. And that's quite a kind of, I hate to say old fashioned, but a traditional way of managing ITP. It would have been to take the spleen out. And it's taken a long time for sometimes some of the funding approval bodies to catch up with all of this evidence. And so what we've been trying to do is say, well, actually, you know, where does splenectomy fit? How do patients do? And this is some early work that has been presented at international meetings over the last kind of couple of years to say, we are doing splenectomies much later. And there's many other treatments that are as effective with fewer side effects used much earlier on. So the number of treatment lines prior to splenectomy you see is lower 20 to 30 years ago than it is now. And the number of treatment episodes, so not just the different medicines, but how often people are having those medicines, is going up quite a lot before we do splenectomy. And there's a whole range here. So hopefully this is showing you how we can start. If hospitals only did these on their own, it would be a handful of patients, and it's very difficult to start to pull things together to be able to really learn and promote best practice for how we get the best outcomes in patients with ITP. And the final bit, just to show you before we stop and others take on, is what we've got out of the first 2 years of pregnancy registry. Now, Dr. Robertson is going to talk in a lot more detail about this with the who's had treatment and how many have had treatment and modes of delivery. But to give you a flavour, we've had 31 women overall recruited, 26 of whom delivered and 21 with complete data sets. And the average age is 33 years, which we would expect. And we've got a good, actually a slightly different ethnic mix within the pregnancy registry than we have within the overall registry, probably more reflective generally. And Sue will talk to you a little bit more then about what we've seen, about how these patients have been managed, what the deliveries look like, what the bleedings look like, and what treatments ladies have needed during pregnancy and what the outcomes for their babies have been. So just to say then, as I come to the end of my time, we have a little bit, we've worked quite hard on being able to, for people to be able to see what we're doing registry-wise, so that I think it's much better that people can understand how things work. So we have a website, feel free to have a look. Within there's some paperwork and things for other sites, but patients are equally welcome to have a look at this website. It's open access. And it's got in there some of the papers and things that we've written and where some of our funding comes from, including the Support Association. We have a Twitter feed, which I'm not very good at with the technology, but we have someone who looks after that for me properly. And we do twice a year, we do some update letters for the sites that just gives them an idea about recruitment, where we're going, whether things have changed, whether any of the regulatory things have changed, and kind of general updates on where we're going next with projects. We're supported by the UK ITP Forum, which is a network of doctors who manage ITP across the country and help steer where we might look, but also very supportive of us as we're trying to access medicines for patients with ITP and promote the newer agents coming through and available from things like the National Institute for Clinical Excellence, and of course the Support Association, Mervyn and the team, who've just been great and so supportive and encouraging, and we're very grateful for the funding that comes from the Support Association to help us to be able to do this. So this is my final thank yous to you, the recruits, to the Support Association, to the recruiting sites, and some additional grants that we've had over the kind of last 10 years or so. And again, quite small, but hopefully you'll be able to see all these different trusts that recruit into the registry. And any questions you have about this, do feel free. I know there's a question forum via the Support Association. We're always happy to answer questions, and thank you very much indeed.